Hello everyone, and welcome to a discussion on CNS Neoplasms. This is part of the Neurology module of First Aid Step 2 CK. So in this module we're going to be talking about neoplasms, and then we will be discussing neurocutaneous disorders. The two kind of interlock with each other, so I thought it would be better to do them together. So, starting with neoplasms, intracranial neoplasms may either be primary or metastatic. Metastatic are more common than primary. All of the brain tumours, out of all of the brain tumours, 40% are benign, and these rarely spread beyond the CNS. One neurologist once told me that a lot of tumours can metastasize to the brain, but primary brain tumours very rarely metastasize to other places. In terms of metastatic tumours, as I said, they are most common, and the ones that you should look out for are mets from the lung, the breast, the kidney, the GI tract, and also melanomas as well. And they usually occur at the grey-white junction, the grey matter-white matter junction. And this is because a lot of the vessels that supply the grey-white matter junctions are usually the lenticulostriae arteries, and essentially the arteries that are at the end of the arterial line, if that makes sense. So they're usually the last place a cancerous cell can get to. They are the most distal vessels in the brain. So if, for example, somebody has a melanoma, one of the cancer cells, if that was to then dislodge and metastasize in the blood, one of the last places it will get to is usually a grey-white matter junction. That's why. They may be multiple, discrete nodules, and are characterized by rapid growth, invasive growth, necrosis, so they're often dirty, and neovascularization. So usually when you're looking at a CT of the head or an MRI of the head, if you see multiple nodules, if you see grey-white matter distribution, and if you see like dirty necrosis, then this is usually pointing towards a metastatic brain tumor. Neoplasms are more common in males than females, except for meningiomas. Meningiomas is the only one that is higher in women, and that's because the arachnoid cells, which is what meningiomas come from, they have got estrogen receptors on them. So that's what links the meningiomas more to women. Most CNS tumours are metastatic, as we've said. Most common primary CNS tumour in adults is the glioblastoma multiforme and meningiomas, and the most common primary CNS tumour in children is the astrocytoma. That's the pilocytic astrocytoma, and that's usually found in the cerebellum, and we'll talk about that later, and medulloblastomas as well. Medulloblastomas are, of course, malignant, astrocytomas are benign, glioblastoma multiforme is malignant, and then meningiomas are benign. So you can remember for adults, one benign, one malignant, and for children, one benign, one malignant. Generally speaking, we will discuss this more later, but pediatric CNS tumours are usually infratentorial, meaning they are below the tentorium cerebelli, and that essentially means they're lower down, whereas in adults, the tumours are most of the time supratentorial, so they're usually in either near the pituitary or in the cerebrum. So let's talk a little bit now about the history and physical examination. So the symptoms really depend on the tumour type and the location, okay? Local growth and resulting mass effect, cerebral edema, and high intracranial pressure can occur, and you can look out for these sorts of things. But generally, when we're looking at tumours, we're looking for high intracranial pressure signs, headaches that are usually progressive, and focal neurological signs depending on where the tumour is. And just before we talk about each individual tumour, I want to just kind of finish off talking about the physical examination. Seizures or slowly progressive focal motor deficits are the most common presenting features, so look out for that. Although headaches are often thought as the main presenting symptom, only 31% of patients actually have the headache at diagnosis, and only 8% have headache as the sole presenting feature. When there is high intracranial pressure, look out for obviously headache, nausea, vomiting, diplopia. The diplopia will usually be due to the cranial nerve 6 of Dussen's palsy, which is the false localizer due to its long intracranial route. And of course, we're doing neuroimaging, so it's relatively rare now to find a patient who presents with high intracranial pressure, because by the time they've got another symptom, they're going to have had some form of imaging, and they're usually going to have identified the tumour and treated the tumour before it gets to that point. But I've seen quite a few USMLE questions that still use high ICP in their scenarios. Some other presenting symptoms could be visual field abnormalities. Of course, if there's a pituitary-based tumour, there's going to cause the bitemporal hemianopia. Neurological deficits, psychiatric symptoms can also be seen as well. So let's go through the different types of tumours. So we'll start off by talking about the astrocytoma, okay? So in astrocytomas, we have the pilocytic astrocytoma, which is a pediatric type. In this case, we will be talking more about the adult type. But we can have anaplastic types, we can have glioblastoma. Glioblastoma is the highest grade, anaplastic is grade 3, so it's slightly lower. Diffuse is grade 2, and then the pilocytic astrocytoma, the child's one, is grade 1, okay? Histology would show astrocyte origin, okay, they're from astrocytes, and very famously is going to be GFAP positive, okay, and that's more of a step 1 concept. On histology, we do see the so-called pseudopalisading. It's called pseudopalisading because the cells are sort of moved in line with each other due to the necrosis infiltrating the parenchyma. This is not real palisading, but it looks like palisading, and that's why it's called pseudopalisading. You can also see areas of hemorrhage, microvascular proliferation as well, and it is associated with amplification as well. So just looking at benign versus malignant, I did say the low grades, diffuse, anaplastic, and then glioblastoma, just in terms of severity. So diffuse is grade 2, anaplastic is grade 3, glioblastoma is grade 4. Anaplastic and the glioblastoma multiforme, these are considered malignant, whereas the diffuse is considered benign. In terms of presentation of astrocytomas, it does depend a lot on location of tumour. Some symptoms include like headaches, seizures, focal neuropathy, we've already discussed these, and glioblastoma is the most common malignant tumour in the brain that's not metastasis. And it progresses usually quite rapidly, and it has a poor prognosis, okay? You will have heard of quite a few celebrities that have had glioblastoma. I know somebody from one of the boy bands, The Wanted, Tom Parker, he had glioblastoma and unfortunately passed away from it. It is rapidly progressive, and it's usually seen in older adults, usually around 50, 60-year-old patients, not young adults. One thing that isn't mentioned on the presentation is that glioblastoma kind of quite famously causes something called a butterfly glioblastoma, which is where it crosses from one side of the cerebrum to the other side underneath the falx cerebri, and that is referred to as a butterfly lesion, and they quite like to show a CT image or an MRI of that in your steps, so look out for that. Treatment, surgical removal, resection, and radiation and chemotherapy can be given. You really don't need to know the extensive sort of treatment for these. Moving on now to the oligodendroglioma. This is usually seen in the frontal lobes. We will look at some pictures in a minute, and histologically it has got a fried egg cell appearance. So if you were to I will show you some pictures in a minute, but the cells are very round, they have very prominent nucleoli, and the cytoplasm is very clear, so they kind of look like fried eggs with the nucleus being the yolk. They also have capillaries interweaving between them, and they kind of look like this in between them like this, and these are referred to as chicken wire capillary pattern. Again, these are more for step 1, but it's kind of good to remember for step 2 just in case. The lower grade oligodendrogliomas, these are very benign, they're slow growing. We can have anaplastic and more malignant oligodendrogliomas, but generally speaking, they are more benign, okay? Oligodendrogliomas, in terms of a presenting complaint, they most commonly present with seizures. However, they can be silent. Age of onset is slightly younger than the glioblastoma multiforme, and it's usually 25 to 45 years old. And a quick kind of neurological link here is that they're most commonly found in the temporal lobes. They can also be found in the frontal lobes. They can also be found in the temporal lobes as well. So the kind of question I would ask you is, what kind of signs and symptoms do you think you would find in patients with the oligodendroglioma? Usually patients may have executive function changes, personality changes, okay? So that's really important to look out for. It's not mentioned here, but it will be used in question stems, okay? So you're looking at maybe a 30-something-year-old man who's got insidious onset of headaches. He had a seizure a couple of weeks ago, and his wife has noted that he's had some personality changes and has had difficulty with executive function. We're looking already at an oligodendroglioma stem here, okay? And they can be calcified as well. In terms of treatment, surgical resection is usually done, followed by radiation and chemotherapy, but these tumours are often chemosensitive, unlike the glioblastomas, so usually chemotherapy is given. Now moving on to the meningiomas. So as I said, meningiomas is the most common benign tumour in adults. MRI brain reveals meningioma with associated dural tail. I will show you that in a minute. Histology, we have lots of different histological variations of meningiomas. One of the most common is spindle cells. We can also have the whorled appearance, which is like a concentric fibrotic appearance. And then we can also have samama bodies as well, which is laminated calcifications. In UWorld and in USMLE, they tend to like to bring up the samama bodies just because they like to test students on which disorders are associated with samama bodies. Generally, meningiomas are benign. Very rarely are they associated with being malignant. And in terms of presentation, the presentation depends on the location. Okay, so meningiomas can be within the brain, but they're usually extraaxial, which means they're usually coming out from the cranium where the meninges are. So usually when you look at an MRI or a CT of a meningioma, they're usually on the kind of periphery of the brain, growing into the brain parenchyma, if that makes sense. Meningioma is often related to cranial neuropathy, and it can actually be an incidental finding as well. A classic imaging finding is an extension of the tumour along the dura, and this is called the dural tail. And I think there's a picture that I'll show you in a minute of that, but it's essentially as the tumour is growing, say this is the skull, this is the tumour kind of growing, it's going to be growing into the brain like this, and that starts to tear away the dura from the cranium, and this creates this sort of dural tail just here, okay? Obviously, the origin of the meningiomas is the arachnoid cells as well. In terms of treatment, surgical resections can be done. In fact, that's the most common treatment, and any tumour that is unresectable, we can do some radiation for as well. Now moving on to hemangioblastomas. So I'll show you a picture of an MRI in a minute, but histologically we are going to have vessels essentially. So you're going to have thin walled capillaries, you're going to be seeing lots of red blood cells within it, and very little CNS parenchyma within it. So it's mainly just capillaries. Most of these are benign, and the high yield things to know about it is that they're most likely found in the cerebellum, and they're usually associated with von Hippel-Lindau syndrome. In von Hippel-Lindau syndrome, expect to see retinal angiomas as well, maybe pheochromocytoma, maybe renal cell carcinoma. So expect to see a kind of constellation of different tumours as well. And another really important thing to note is that they can produce erythropoietin, so expect a secondary polycythemia, i.e. an increase in hematocrit, but EPO is high, okay? Surgical resection is done for a lot of hemangioblastomas. Radiation therapy is sometimes used in recurrent cases as well. Again, nothing specific for us there. Now I want to move on to the pituitary adenoma. So again, I'll show you an MRI scan of the pituitary adenoma in a minute, because that's really high yield to be able to pick up in your board exams. And histology, it kind of depends, but you're going to be seeing a hyperplasia of endocrine cells found in the pituitary, okay? But it does depend on which types of cells you have, whether it be a prolactinoma or whether it be a growth hormone producing tumour, so it depends. Most pituitary adenomas are benign. Some of them can become cancerous and extend into the local structures, but that's not really so important. Just for sake of your boards, they're benign. They can be functional, as we know, but they can also be non-functioning or hyperfunctioning, okay? So the non-functioning tumours, these are called silent. These mean they're not producing any hormones, okay? Or they're not producing any hormones systemically. You can actually have functioning adenomas, but they don't produce the hormones into the blood. So they can locally produce it, but not produce it into the blood, okay? But a non-functioning, just for sake, is not going to be having hormonal effects. And then, as I said, we can have hormone producing. Non-functional tumours, they will present with just the mass effect, okay? Bitemporal hemianopia, okay? That's where your vision is lost on the outside. So you have the so-called tunnel vision, okay? That's just because where the optic chiasm is very close to the pituitary gland, so any mass can potentially catch the optic chiasm, which carries the peripheral optic fibres. Pituitary apoplexy can also be seen as well, and we discussed that in more detail in the endocrine unit. But pituitary apoplexy usually presents with a thunderclap headache, maybe signs of bitemporal hemianopia, and signs of hypopituitism usually. Prolactinomas are by far the most common pituitary adenoma, and we discussed that more in endocrine. But it classically presents with galactorrhea, amenorrhea, decreased bone density, and that's just because prolactinoma has a negative feedback on GnRH. Therefore, the patients will have less LH and FSH. Therefore, patients will have less estrogen in females and less testosterone in men. So you're going to have a lack of libido, infertility, erectile dysfunction in men, and then amenorrhea, galactorrhea, and a decreased bone density in women. In terms of the workup, for pituitary adenomas that are functioning, it becomes almost like an endocrine workup, okay? So we're going to be doing a brain MRI with gadolinium, okay? And then we're also going to be doing prolactin, IGF-1, which is related to growth hormone, ACTH, a 24-hour urine-free cortisol, of course. Additional tests can also be TSH, LH, FSH, purely based on clinical presentation, okay? So if you see the patient has signs of hypothyroidism, maybe they have a pituitary adenoma that's producing TSH and they now have secondary hypothyroidism, okay? So essentially, this is where endocrine meets neurology, okay? But just keep it in mind that prolactinomas are by far the most common, so if you want to memorize one of the signs and symptoms, memorize it for the prolactinomas. Okay, just a couple of other things that I kind of have missed off from the pituitary adenomas. We do have the lactotropes, as I've already said, so we get signs of hyperprolactinemia. Less commonly, it can be growth hormone, so look out for people with acromegaly if the epiphyseal plates have closed and they're adults, or gigantism if the epiphyseal plates haven't closed and they are pre-pubertal. Corticotrophs as well, so these are ACTH producing cells, so the patient would have Cushing's, and remember, Cushing's syndrome is just anybody with high cortisol, and Cushing's disease is a type of Cushing's syndrome that is specifically from a pituitary adenoma. That's just to make sure the nomenclature you have is correct. Rarely it can be from thyrotropes. This is incredibly rare, but that would be your secondary hypothyroidism, and rarely gonadotropes as well, FSH and LH. So you're not going to be doing TSH, LH, and FSH in your workup unless you suspect this. One thing I want to mention, other than doing treatment like surgical resection and stuff like that, for our that's not what I meant to do. For our prolactinomas, we can be using dopamine agonists, okay? So this is a really important recap of your kind of endocrine physiology. Of course, as you know, prolactin is produced from the anterior pituitary. Dopamine, okay, so DA for dopamine, has a negative effect on prolactin release, okay? So dopamine naturally inhibits prolactin release. Dopamine also has a negative trophic effect on the cells. So it doesn't only decrease prolactin, it also inhibits lactotrophs from proliferating. So if I can give a dopamine agonist, that can not only decrease the amount of prolactin produced, which can relieve the symptoms from a prolactinoma, but it can also stop the cells from hyperplasing. So it kind of acts as a bit of a chemotherapeutic in that regard as well. But as I've already said, a lot of the patients do require a transsphenoidal resection, so surgery. And then one of the last tumours I want to kind of mention is the schwannoma. Okay, so a schwannoma is also called an acoustic neuroma. This is coming from the Schwann cells, from myelin, from essentially a peripheral nerve. So while all of the others that we've mentioned are CNS tumours, this is kind of a PNS tumour, okay? Because it's coming from the myelin, from a peripheral nerve, not from a central nervous system cell. So I'll show you a CT of what it looks like in a minute, but Schwann cells, these will be testing positive for the stain S100. That is a myelin-based stain, so these will be positive for that. And in terms of histology, this is really not so important, but you have the so-called Antony A and Antony B, which is where we have hypercellularity in Antony A, hypocellularity in Antony B, and they're usually spindle cells as well. Okay, but this is not so important for you to remember for step 2. Most of them are benign, okay, so we're just going to have symptoms based on compression. Most of the time, the schwannoma will be at the cerebellopontine angle, and that is an anatomically significant position because cranial nerves 8, so your vestibular-cochlear nerve, and cranial nerve 7, i.e. your facial nerve, these exit the brain at the cerebellopontine angle. So that's where we're going to have compression. So expect to see signs of facial numbness, weakness, hearing loss, tinnitus, vertigo, and a loss of balance. Okay, that's just testing whether you know cranial nerve 8 and cranial nerve 7 signs. If the tumour's left to get big enough, it can compress some of the other cranial nerves, okay, like cranial nerve 5, cranial nerve 9, cranial nerve 10, etc. And a hallmark to remember for NF2 that we're going to discuss in a minute is bilateral schwannomas. Okay, if a patient has bilateral vestibular schwannomas, that's NF2 unless you prove otherwise. Okay, and for these patients we're going to be doing surgical resection, but we can also do focal radiation in some patients, maybe just monitoring as well. So I said I was going to quickly show you some pictures, so let's just go over it. This is a very poorly pixelated picture, but you can see this is glioblastoma multiforme in A. You can see the areas of pseudopalisading. So this is necrosis coming up here, and it's pushing the cells to the side, so it looks like it's palisading. This is also a glioblastoma multiforme in the cerebrum, and you can see that there's areas of necrosis in the middle, and you can also see there's some reactive edema around it. So this is very common for glioblastoma. In C, I hope you can have a guess of what this is. Excellent, this is the oligodendroglioma. So you can see the cells that have got a very clear cytoplasm and a very clear nucleus. These are my fried egg appearance. And can you see these little things here? These are my chicken wire capillary vessels, okay? Excellent. I'm just going to try and move on as quickly as I can. In E, this is a hemangioma, okay? And F represents the histology of that. As we said, hemangiomas are more commonly found in the cerebellum. And as you can see here, we can see lots and lots of vessels because you can see all the red blood cells, so always look out for that. And there's not much parenchyma around it, so it's mainly just vessels. In G, you're going to very commonly get a picture like this. You've got to look around, and you spot that there is a mass here. This is in the sella caternica, in the pituitary area, and that would be responsible for the pituitary adenoma. And then finally in H, you can see two kind of masses that are kind of almost coming into the cerebellum. And these are vestibular schwannomas, okay? And a big differential for these when you see this is meningiomas, because some meningiomas can occur in this area and they look very similar. They're never going to get you to differentiate between the two of them, but just in clinics, look out for that. But if I was to show you this, what disorder would you suspect this patient has? Excellent. NF2, okay, because they have a bilateral vestibular schwannomas. Good. So now we're going to be just moving on to the diagnosis. I do want to mention just this mnemonic. This is the most common cancers that metastasize to the brain. So lung, skin, GI, breast, and renal. The skin being a melanoma, not like a squamous cell carcinoma. Okay, so melanoma, not anything else. Okay, let's talk now a little bit about diagnosis. So the best initial test for a suspected brain neoplasm is a CT and MRI with and without contrast. And that's essentially just to localize the tumor and determine the extent of the lesion. If somebody has a soft tissue tumor, they tend to use gadolinium enhanced MRI. It's better for visualizing that. Whereas if you have any skull-based lesions, a CT tends to be easier to visualize them. Also, if somebody has maybe like obstructive hydrocephalus or something, you can do a CT because it's a lot quicker and it's a lot more rapidly acquired. Histological diagnosis via CT-guided biopsy or surgical biopsy is required in most cancers, okay, in most of those cancers, but not all of them. Just a quick fact, I've already touched upon this, but 2/3 of primary tumours in adults are supratentorial, whereas only 1/3 in children is supratentorial, okay? So in adults, we usually see supratentorial tumours, whereas in children, it's infratentorial, because only 1/3 is supratentorial. If I was to say a patient who is a child, maybe like 4 or 5 years old, has a pituitary-based lesion, what kind of diagnosis is this most likely? Is it most likely a pituitary adenoma? No, it's not likely a pituitary adenoma. This is usually a craniopharyngioma, okay? And we discuss that more in the pediatric section. Good, so now let's just talk about treatments. We've briefly discussed them in each neoplasm, but just as a whole, we should consider resection if possible. Radiation chemotherapy is often done alongside it. It's like an adjunct treatment, but this will depend on what kind of tumour we have. Therapy is highly dependent, as I've already said, on tumour type, histology, progression, etc. But something that we will be tested on more in step 2 is if the patient has high intracranial pressure. What are some of the things we can do? So head elevation is probably the single quickest and easiest way to decrease ICP. Okay, that actually decreases the venous outflow and allows a decrease in the ICP. Hyperventilation, okay, that's called therapeutic hyperventilation. When you hyperventilate, you breathe off more CO2. That is going to raise the pH in the blood, and that's going to cause cerebral vasoconstriction. Okay, so that's going to decrease the amount of edema. Steroids can also be given to decrease vasogenic edema as well. And then, of course, your mannitol and hypertonic saline can be given in more extreme cases. If somebody's got an incredibly severe high ICP, we can remove the CSF, usually via a ventricular portal shunt. I do want to just mention that if somebody's got high ICP and that's due to a lesion, like a cancerous lesion, a neoplasm, it's usually contraindicated to do a lumbar puncture because of the risk of herniation. So if you want to remove CSF, it's got to be via some ventricular shunt. And then they've also mentioned something about defibrillators. I've never really come across this, to be honest. I know defibrillators are usually used for like cardiac arrest, but it can in this case be used for seizures. And then finally, last but not least, just going over the symptoms of ICP. This is important across specialities: nausea, vomiting, diplopia. Okay, diplopia, can you recall why? Excellent, it's due to cranial nerve 6, which is my abducens nerve, palsy. Okay, and a headache that is worse in the morning and worse when bending over or with recumbency. This is a really telltale sign, okay? Most patients don't have a headache that's worse in the morning, so that's telling you that it's probably a high intracranial pressure. Of course, in the questions, you're probably going to get ideas that they have papilledema on sort of fundoscopy, but just from symptoms, nausea, vomiting, diplopia, and a headache worse when lying down or in the morning. Okay, so that's everything from CNS neoplasms. I hope that was helpful, and I would advise to do this video alongside the neurocutaneous disorders.